I've got the task of explaining thrombophilia to everybody, and I should say that the average doctor doesn't really understand thrombophilia, so we're starting from a very difficult point. So let's go through it, and we'll come from the basic definitions right up to date. So the aims of the talk are to answer the questions: what is thrombophilia? Does it increase your risk of having a blood clot? Does it affect the way you might get treated? And can we detect it easily? Okay, so you should be able to answer all those questions at the end of this talk. So we've got two definitions of thrombophilia, and we've got the American definition and the British definition. And the Americans have come up with this lovely fluid definition, and the Brits have come up with a slightly stilted definition. So here we go. So thrombophilia is individuals who appear to have a predisposition to deep vein thrombosis and pulmonary embolism, which is what venous thromboembolism encapsulates. And in the UK, we say, in a slightly upper crust way, the familiar or acquired disorders or the hemostatic mechanisms which are likely to predispose to venous thrombosis. So they're both trying to say the same thing with a different set of words. We're talking about having a blood condition which is making your blood more sticky and more prone to venous thromboembolism. Now, it's important to stop here because we're talking about blood clots in the veins, and we're not talking about blood clots in the arteries. Blood clots in the arteries, heart attack is a blood clot in the coronary arteries supplying the heart, or in the brain, if you block one of your arteries, you will have a stroke. So these aren't risk factors for stroke or heart attack. These are risk factors for deep vein thrombosis. And when we look to do and test somebody for thrombophilia, we have a whole list of different conditions that we can check for. And we divide them up into inherited, so you were born with it, or acquired, where you don't have it, you weren't born with it. It's something that's happened within your blood, usually as an adult. And so we have got a fair number of factors here. So if we just have a look at the acquired thrombophilias, the key one is antiphospholipid syndrome, and that's you develop an antibody in your blood against phospholipid that makes your blood more sticky. And this is when we start breaking the rules. So we talked about the fact that these risk factors are only for venous blood clots, but in fact, antiphospholipid syndrome breaks all the rules, and it can actually cause stroke, and it can cause heart attacks, and it can cause blood clots really anywhere in the body. And then the other ones are myeloproliferative diseases. This is when you make too many red cells, too many white cells, or too many platelets. Cancer. Cancer is a major cause of blood clots. 10 to 20% of people who have cancer will have a blood clot. And if you have quite bad cancer, if you don't die of the cancer, the second commonest cause is a blood clot. And then right at the bottom, I've put the small print. This is for people like me, and I'm really, really looking hard at somebody, and I think, there's really something going on. I might test for these particular problems at the bottom. Now, thrombophilia screening has really not been a very popular thing to do among hematologists for the last few years. So the first thrombophilia screens were sort of invented in the late 80s and the early 90s when we discovered all of these inherited problems that would predispose to having blood clots in the veins. And when they arrived, we thought, this is the answer to everything. We can look at people who've had a blood clot, if they've got a family history, and we'll be able to say, this is exactly the problem that precipitated the blood clot. So we thought, yeah, let's go for it. So everyone was doing thrombophilia screens right, left, and center. And then we started to recognize, actually, we weren't finding out the cause of people's blood clots in a lot of cases. And we sort of got very disillusioned with them a couple of years ago, and we're sort of coming out of that now and thinking about how to use a thrombophilia screen reasonably. So this is the problem with thrombophilia screens. They're not understood. So if you run the laboratory that does the tests, as I do here, you find that many doctors ask for the tests inappropriately. So up to about 5 years ago, when we audited what was going on, 2/3 of the people who'd asked for thrombophilia screens were actually asking for the wrong reason. Somebody might have had a heart attack or a stroke or miscarriage, and they were asking for a thrombophilia screen, and it wasn't appropriate. The patient didn't have a deep vein thrombosis. And then if we look at the inherited factors, we found they didn't explain everything. So I don't know if you remember, but Dr. Robinson said, well, if someone has a blood clot in pregnancy and they've got a family history, we know that we'll find a thrombophilia in about half of them. And that's actually true outside of pregnancy. So if this whole room here, if we all had had a blood clot, and your mother and your maternal grandmother and your sister or brother had all had a blood clot, and we checked you out for all the inherited factors we know about in 2015, we'd only pick up defects in about 50% of you. So that means there are lots of people out there, they have an inherited thrombophilia, but we can't put a name on it because we don't know enough about clotting. And one of the problems with thrombophilia is we used to find someone with a defect, and then we'd look at all of the family, and they'd all get labeled, and they would become what we would call the worried well. So something like factor V Leiden, on its own, it does slightly increase your risk of blood clots, but most people with factor V Leiden will never have a blood clot. So should you be telling them that they've got factor V Leiden and make them really, really worried that they've got a slightly increased risk of having a blood clot? Whereas we know these days, if you go into hospital in England, you'll get adequate blood thinners, or at time of risk, you get adequate blood thinners. And then the other problems are, we're a population from all over the world. If you walk down the street in London, you will see faces whose backgrounds come from Africa, Asia, Russia, all over the place. And in actual fact, the research on thrombophilia has only been done in the white European population and in North America. So if you come from Asia, if you're Chinese, if you're African, no one has looked at that population to see what the inherited thrombophilias are. They might be the same, they might be different, but they're not very useful thrombophilia screening isn't very useful to do in someone who's Asian. For example, the two commonest defects that we see, factor V Leiden and something called prothrombin 2210, are only present in white people. We don't see them in Africans or Asians. So when we talk about inherited thrombophilia, this is the type of thing that we expect to see when we talk to the patients, that there's normally a family history, that if you've got sticky blood, you'll have a blood clot at an earlier age than a normal individual, and you might have recurrent events, because your blood's so sticky, and it might be in an unusual place. You might have a vein in your head or a vein in your tummy. Tend to have thrombosis during pregnancy or after pregnancy because blood gets very sticky in pregnancy. And occasionally you see people who have just had blood clots out of the blue without any obvious precipitating factor, and they may have just inflammation of the superficial veins, superficial thrombophlebitis. So we've said lots of things. So we said thrombophilia screens aren't as useful as we thought they were. They're really only useful if you've got a family history and you're white. And the other problem is, if you have a thrombophilia, they're not all the same. So we've got the high-risk ones. If you have antithrombin deficiency, antithrombin is a natural blood thinner. If you've only got 50% of antithrombin, then you've got a very high risk of having a clot. And it's the rule of 50% in antithrombin deficiency. I teach them, the medical students, and I say you've got a 50% chance of having a deep vein thrombosis before the age of 50. And if you get pregnant, when the blood gets sticky, you have a 50% chance of a DVT in pregnancy. So that's really, really high risk. 1 in 2 will have a blood clot before the age of 50. And then at the other extreme, we've got the lower risk one. So factor V Leiden, if you just got 1 dose of factor V Leiden, you're increasing your risk of having a blood clot about 8-fold. Woo! My goodness. There we go. Close one. So factor V Leiden increases the risk by about 8-fold, but actually an individual's chance of having a blood clot is very low. And then we've got prothrombin 2210, and that has only been shown to double the risk of having a blood clot. So these are tiny, tiny increases, whereas antithrombin increases your risk at least 80-fold. So the message from this slide is that the thrombophilias aren't all the same. We treat them all very differently. And actually, why are some of them so common? Because if we consider evolution, there must be an advantage to having some of these thrombophilias. So if we look at factor V Leiden, this is about 5% of the white population. It's so common that actually 1 in 1,600 have a double dose of factor V Leiden, which does make your blood a lot more sticky, and you've probably got an 80-fold increased risk of having a clot. What we know about factor V Leiden is probably the very first person that had factor V Leiden was born out in Turkey or the Middle East, and it spread across Europe towards the British population. So if you were to go to Turkey today, about 10% of the population have factor V Leiden. As you come out across Western Europe, in France it's about 5%, in the UK it's about 5%, and it's in between those countries, it's midway. But it's rare in the west of the world, so not in Africans, not in Asians, not in Indians. And the question is, why has it spread so successfully? There must be an advantage to it. And you only really have to look back to before Victorian times and remember that the chances of women dying before the age of 40 was very, very high in Victorian times. And they died mainly in childbirth from hemorrhage and infection. And the thing about having factor V Leiden is that if you bleed, you don't bleed so much. So that if a woman had factor V Leiden, they were more likely, if they had a bleed after they had a baby, to survive. And so this has led to its spreading. And it's only now in this very modern world where we spend all of our lifetime sitting around, perhaps in front of computers or whatever, we're starting to get overweight, we don't have such active lives, that the downside of the factor V Leiden comes into operation in that we are more prone to having blood clots. So before Victorian times, it was probably a major advantage. So the last thing to say about blood clots is that we do think about them in a different way these days than from even 5 to 10 years ago. And we divide up blood clots into provoked and unprovoked. What do I mean by that? I mean, if you have been on the pill, if you have been into hospital, if you have been on a long-haul flight, if you have taken certain hormones and you have a clot, it's probably those factors that are the major cause. And the unprovoked are those people who don't appear to have anything happening in their lives to make them have a clot. And it's very important to think about them in this way, because we've got quite a lot of evidence now that if you have a provoked clot, if you stop the factor that caused it in the first place, your chances of having another one are very low. And it really comes from this research that was done at Addenbrooke's by two people who are married. So it's Trevor and Caroline Baglin. Trevor's the hematologist there. Caroline is his thrombosis nurse. And they got together a group of patients, so 570 patients, who'd all had a blood clot. They didn't have cancer, they didn't have antiphospholipid syndrome, and they divided them up into those who'd had provoked and unprovoked blood clots. And here we've got the list of the provoking factors. So they'd had recent surgery or trauma, they had reduced mobility or pregnant, or they were taking estrogen-containing medication. They gave them the normal treatment with warfarin, stopped the treatment, and followed them up for 2 years. And they found that in those who'd had a provoked event, nobody had another blood clot. Whereas in those that had had unprovoked events, so something probably going wrong in their blood within, 19% had another clot. So there's other research like this now, which is saying the same thing. If you have a provoked event, you don't need to continue with anticoagulation more than for a short period. We feel very reassured you won't have another clot. It's those who have unprovoked events that we're concerned about. So the next thing to say is, what about the testing? So if we look at testing in all of the labs across the country, they all have to follow their own internal processes and they have to quality control what they do. And then we have a national quality control service and they send around samples to all the labs and they won't say what the problem is and they'll check that the laboratory gets the blood tests right. And what this is here, this is the results of sending around a sample, a couple of samples to the labs, and both of the samples had an abnormality within them. And they were tested in the laboratories. And what I want you to notice is that we've got two samples here. One is meant to be short in protein C, so that's protein C deficiency. 91% of the centres reported the patient had protein C deficiency, but 9% missed it, and 25% reported protein C deficiency, and actually there was no problem with protein C. Now these are the two worst tests to be doing, protein C and protein S deficiency. They're not done well nationally, so I'm saying to you that the tests aren't ideal in all the labs. So let's look at what the guidelines say now and see what they're telling the doctors to do if someone has had a blood clot. So we've got the British guidelines, British Society for Haematology guidelines on testing for heritable, inherited thrombophilia. You might see my name there. And they say, because of all this poor evidence, because of the poor testing, because we know that provoked events don't tend to recur, because we're generating lots of worried well, that we shouldn't indiscriminately test people. It's also very expensive. And decisions regarding duration of anticoagulation in unselected patients should be made with reference to whether or not a first episode of venous thromboembolism was provoked. So just going back to what I said, if it's provoked, you don't need to have any thrombophilia testing. And then we've got the American College of Chest Physicians. This is a very good international agency, and they have said if you have a provoked event, you should have 3 months anticoagulation and you can stop. If you've got an unprovoked event, you should have 3 months, then assess and decide with the patient whether they should have long-term anticoagulation. So this is the actual end of the British Society of Haematology guidance. And they're saying testing for heritable thrombophilia in unselected patients, such as those with strong family history of unprovoked recurrent thrombosis, may influence decisions. It's not possible to give a validated recommendation to how such patients should be selected. So they're actually saying if you do have somebody who has a really nasty thrombophilia, such as antithrombin deficiency, you might want to think about looking at the family, but otherwise probably not. And that's saying the same. So where we're heading to with thrombophilia testing is that we should only really be using it if it's going to affect the management of the patient. And this is where we come to the NICE guidelines. Now, the NICE guidelines have to be followed by everybody within England. They are meant to be followed by Wales. And Scotland, they have their own guidance called the SIGN guidelines, and they are very similar to the NICE guidance. And this really says where we are. These were written in 2012. And I want to just go through them with you, and I want you to recognize that it says don't more often than does. So here we go. It says, do not offer thrombophilia testing to patients who are continuing anticoagulation treatment. So it's sort of saying, if you know someone's got a really bad problem, so if they've had a blood clot out of the blue and they've nearly died, you're going to probably continue long-term anticoagulation. You're not going to want to stop the anticoagulation, which you'll need to do to check them for thrombophilia. It's not going to affect your treatment, so you carry on. Consider testing for antiphospholipid antibodies in patients who have unprovoked blood clots, and it is planned to stop treatment. So if you're not sure whether to continue, you should really check them out for antiphospholipid antibodies. And then consider testing for hereditary thrombophilia in those who've got an unprovoked clot and they have a family history, and if you're not clear whether or not to continue with the anticoagulation. It says, do not offer testing to patients with a provoked blood clot, which we know is quite safe because they shouldn't have another, and do not routinely offer testing to first-degree relatives with a history of VTE and thrombophilia. So for somebody with factor V Leiden, we wouldn't test the rest of the family. The strong family history would mean that that was enough. We would probably not need to offer thrombophilia screening. So there's a whole separate section on antiphospholipid testing, and it's saying, actually, it's probably not being tested for enough. If you've got unexplained arterial and venous thrombosis, or we know antiphospholipid syndrome causes pregnancy loss and preeclampsia, small babies, it should be checked for them. So really the conclusions are, quite often when in the old days when we used inherited thrombophilia testing, it wouldn't change what we did with the patient. We should be doing antiphospholipid testing more frequently in people who've got unexplained blood clots. But if someone has got a provoked event, they don't need thrombophilia testing. So just to go back to the beginning, so there's a list of questions. What is thrombophilia? And we know the definitions now. It's the inherited and acquired predisposition to develop venous blood clots. Does it increase the risk of VTE? Yes, but very variable, some more than others. Does it affect treatment? Not in those who've got provoked events, only in some who've got unprovoked events. We've discussed provoked and unprovoked VTE. And the last is, can we detect thrombophilia easily? And I just want to point out to you that the tests aren't quite as good as they should be yet, and we can't find a cause in 100% of people with a family history. So thank you very much, and I'm very keen to take questions because I appreciate what a lot of us said is quite difficult. Thank you.
Hello.
Hello.
Richard Lovell. How do you determine whether a VTE is provoked or unprovoked?
So provoked means that something has happened that we know is a provoking stimulus. So if we look at all of the blood clots that occur in the United Kingdom, 55% follow hospital admission. So they either occur during admission or usually up to 90 days afterwards. And then we've got things like trauma, and we've got things like the pill, pregnancy, long-haul flights, all those. We've got a list of factors that can provoke them.
So a long car journey could be a provoked event.
So the thing about long car journeys is, for me, it's a minor provoking factor, and I would really take quite I spend time over the history, or how long, and which leg was it? Do you have an automatic car? Did you really have that leg still for 3 to 6 hours, which is, I think, what is normally required? Most people on a long journey will take a break. So actually, and whilst you're saying all these things, long car journeys can precipitate clots. It's all about immobilizing the leg for long periods. Just sitting here and not moving your legs for 90 minutes drops the blood flow through the back of your knee by about 50%. So immobility is an important factor.
Thank
you. I was deemed to have an unprovoked pulmonary embolism despite being on the pill, because I'd been on the pill for a long time. And then when they did their tests, I'm no longer on anticoagulation, although I'd been on warfarin for a year. They said that my protein C and protein S tests were inconclusive. Would you suggest that I should have those again, because they still haven't really identified any cause for that, and I am no longer on anticoagulation therapy?
Okay, I can't talk about an individual case. To sit down in a closed room for 40 minutes and examine everything like that. So if we look at provoking factors, protein C and protein S deficiency, they're very, very rare. They're 1 in 5,000, and it depends on the problem within the protein C or the protein S gene as to how sticky your blood is. If you've got no family history, it's very unlikely to have a significant protein C or protein S deficiency causing a problem. I'm sorry that's so iffy, but it's the truth. Okay.
Hi, you say APS, we're not born with it. Do you know where it comes from?
oh, I'd have a Nobel Prize and I'd be sitting by a pool in Miami with a pina colada if I knew that. So it's an autoimmune condition, and we know that people who have autoimmune disease, they just have a tendency to make antibodies. What the current theory is that it's an antibody to a protein in your blood, and the protein is called beta-2 glycoprotein 1, and it normally circulates curled up. And when you get an infection such as sore throat, streptococcus or staphylococcus, one of the things it does is it opens it up, this protein, and exposes the inner surface, which isn't normally exposed. And for some reason, people with antiphospholipid antibodies are making antibodies against this inner part of this protein. When you recover from the streptococcus, the protein closes up again. So it's something probably to do with infection, precipitating this protein opening up, and then something about the individual which makes them more prone to develop the antibody. Does that help?
What you were saying over thrombophilia testing, say, like Francesca was saying, you've got a patient who's quite clearly stressed about what they've got, what's caused the thrombosis, whether it's provoked or unprovoked. What would be the guideline then over testing? Would you counsel and not test, or test and give that person possibly a reasoning in their mind why they have had that thrombosis? Because I know that sometimes that really helps if you've had something to know that it's got a name and a reason as to why you've had it.
I was talking to one of the nurses here in the break about this, and I think it's very difficult, and there's a lot of people here today who are here because they didn't get answers out of doctors, and they didn't have holistic care, and they didn't have the reassurance that they should have done in the first place. And I don't think doing a set of blood tests is the right answer if someone's already had the screen before and it's negative, and it's helping the patient come to terms with what's happened to them and to give them appropriate treatment at the time that's important. Is that enough, Claire, or do you want more than that? Some people like to be put in a pigeonhole. Doctors like to put people in pigeonholes, but I am very happy if someone keeps having blood clots, and despite anticoagulation or whatever, I'm very happy to believe they've got very sticky blood, and I would treat them appropriately. And putting a name doesn't always help people get the right treatment.
I don't think it's so much regarding the treatment. I think it's more regarding the psychological side of it to them, because I know when I was first diagnosed, and you know yourself, it took me, 9 years to find out what was up with me. I was always told, it's an undiagnosed clotting disorder. But it does, in a certain psychological sense, if you can say, okay, I've had a blood clot because I've got factor V Leiden. I might not have any more, but I've got a blood clot because of that. It helps psychologically sometimes, regardless of treatment or whether you're going to carry on warfarin or you're not going to carry on. Sometimes it helps just to have a name rather than told, oh, well, it's 50% of a clotting disorder that we don't know what's causing it. And you sit there then, because it can cause you to psychologically constantly look for a reason. Do you know what I mean? Yeah. It's so more of a psychological than a treatment aspect.
But that's why I'm saying to you all, as a patient group, as the best tests I can offer you in 2015, if you all had inherited problems, you all had mothers, fathers, sisters with problems, to only put a name on it in 50% of the cases. that's the real world, and I understand that you have a need to know, but that's all I can do at this current time. That's all we can do.
We're overrunning a bit, so this is going to be the last question for now, but you can all have the opportunity to ask questions later.
Thank you. Thank you. That was a most interesting presentation, and this is a very quick question. You mentioned the NICE guidelines, and if I heard correctly, you said that doctors had to go with them, but they are guidelines. Could you comment, please?
Okay, so what we mean by a guideline is something that will apply to 95% of patients. So if you're running a clinic and you're seeing 100 people with a blood clot, you follow those guidelines in 95% of the patient. But there's always going to be a patient who breaks the rules, and you break the rules. But they're just there to help young doctors, people who are unexperienced. This is a standard of care that we expect you to follow. So the whole point about NICE guidelines is that they bring up the standard of care, because we know that, and we've heard already, that the standard of care is very patchy, and we need to bring up the general standards. So they say things like, if someone has a blood clot, these are the blood tests, this is the imaging that needs to be followed to get a baseline standard of care.
Thank you, Beverley.
Yeah.